It is 10:29 at WPSL 1590, the Talk of the Treasure Coast, live from three separate areas of the planet.
Hey, good morning. Welcome to Bone Talk. I'm Dr. Joe. Where's Becky?
Live.
Coming to you live. We're doing a Zoom call, so we're on audio, we're on the radio, and I'm coming to you live from Florida Orthopedic Specialists. And I have my partner, Dr. Jason Williams. The first time that we've been able to schedule something and get Dr. Williams on. And Dr. Williams is our spine specialist, fellowship trained in interventional pain medicine. Thanks for coming on, Dr. Williams.
No problem. Thank you for having me. How is everyone this morning?
Doing great. Doing great.
We're freezing to death, doctor. What are you talking about?
Oh, man. I'm from Colorado originally. This ain't freezing.
Yeah, that's real cold. I just got back from Minnesota. That's real cold.
Yeah, it ain't freezing.
This is spring weather for both you guys.
Yeah, this is shorts weather, that's for sure.
Yeah, so Dr. Williams, so we're always getting all kinds of calls here on Bone Talk about people with spine pain and radiating nerve pain and peripheral neuropathy and, hey doc, I failed this and this, and what are my other treatment options and whatnot. And so I guess, where do you want to start? I mean, should we talk about just low back pain and common symptoms, or how do you generally approach it kind of when you just talk in general to people about back pain and the interventional procedures?
So like for me, what I tend to notice, or like what we see at our practice a lot, is they'll not necessarily come in with like back pain, right? It'll be, hey doc, my knee hurts. Hey doc, my hip hurts. I got this weird feeling in my foot. Those are the kinds of things that we hear. And when they come in and we start checking them out, we're like, wow, this isn't your hip and this isn't your foot and this isn't any of that kind of stuff. And then we tell them erroneously, probably on my end, I go, well, you have back pain there. And they'll say, well, doc, I don't have any pain in my back. And probably a better term is like, the way I try to think of it is like downstream. So a lot of the nerves that come out of your back, they affect things downstream. So you may feel your knee as the problem or your foot as the problem. And one of the classic terms people use is sciatica. Probably a better term is something we use is called lumbar radiculopathy. That's where you get a little irritation of the nerve from your back, but you're feeling it downstream from just overall degenerative spinal changes, like over time, or maybe you've had an accident, or maybe you're a sports star and you've had a disc go out and it starts to pinch the nerve. And so that can irritate the nerve, make the nerve swell and cause problems downstream with like tingling and burning and foot pain and things of that nature downstream. And that's a separate thing from peripheral neuropathy, but that's if you're talking about what we call radiculopathy. Another thing that can kind of cause back pain is what they call the facet joint. And the facet joint is a little joint that lives in the back that allows certain motions, but also prevents others. And it lives outside of the spine. And it's more outside of where the spinal nerves live. So people get overgrowth and arthritis of these. And I kind of think of them as the back's little knee joint. So it has it's kind of set up like a knee joint. It has its own disc inside the joint. It has its own capsule that keeps the fluid in there. It has its own nerve that's not the spinal nerve that contributes to the lumbar radiculopathy, but it can cause vague back pain that can refer pain. So you feel, pain in areas like in the low back or into your butt or down in the back of your thigh. I'm trying to use, general terms here. I don't want to get too medical termy on people. But that can feel like, man, doc, I have this back pain and it's worse when I bend or twist or, whatever it is that aggravates them. And it's treated different. Most people, when you talk to them, they're like, yeah, I had an epidural, or I had, for this nerve, but that's not necessarily, you don't treat facet pain with an epidural. It's treated with a different kind of injection. Some people will call them facet injections. And the analogy there is, if you come in with knee pain, I can put a steroid injection into your knee, right? Like inside the joint.
Sure.
That same thing in the facet is called a facet injection, where they try and put steroid inside the interior of the joint with a little bit of medicine. Those have been found not to be that helpful. And they're harder to do the older you get, because the more arthritic the joint is. And if you put too much volume of medicine inside the joint, it expands the joint, and then you're at risk of that joint rupturing. So when they've done studies about facet injections versus another type of injection to treat facet pain called a lumbar medial branch block, the lumbar medial branch blocks tend to be a little bit better at predicting, is this pain coming from your facet joint versus coming from muscle tightness or nerve irritation, like a radiculopathy or something of that nature.
And that's, you're talking about the test block before you'd actually do the rhizotomy. A lot of people have heard about rhizotomies or radiofrequency ablation. So you're talking about that test block with lidocaine first.
Right, exactly. And so most people will do the lumbar medial branch block. In rare instances, they may try a facet joint injection, but that's not, like I said, the research doesn't show that to be the beneficial of the two. And then sometimes they use the words erroneously or interchangeably, but they're really not. So the facet joint itself has its own set of nerves, and that nerve is called the lumbar medial branch nerve. And there's lateral branch and an intermediate branch, but for discussion purposes for us, it's called the lumbar medial branch. And that is the temporary nerve. It's a sensory nerve that gives sensation to the joint. So again, I'll use the knee again. So there's some nerves that help control knee pain. Some of them are called the genicular nerves, which are sensory nerves around the joint capsule. Some of the other ones are the anterior femoral cutaneous or the inferior saphenous nerves. And these are sensation nerves. They don't control strength. They don't control any of that stuff. Well, in the lumbar spine, it's called the medial branch nerve, and it controls the sensation to the facet joint and kind of that area there. And so we want to know with back pain, is it coming from that, or is it coming from, you know, the muscle, or is it coming from the nerve underneath in the radiculopathy sense?
Because oftentimes in back pain, they have a mixed collection. They have this mixed bag of everything. They have
really
arthritis in the facet joints that you're talking about. They have old herniated discs and some stenosis too. And of course, that's going to come with muscle pain too. So you have a little bit of everything, and you're really trying to figure out what's the primary driver of your biggest symptoms.
Right. And it's really hard. Back pain is very difficult to treat. It's very common. It makes people's quality of life very miserable. You know, you got everything is attached there. Your hip joint is there. Your sacroiliac joint is there. All the muscles, everybody thinks they have piriformis syndrome, which is really rare and like usually not.
Everyone's got piriformis and sciatica. Yep.
Yeah.
These are one little part of a big mixed bag of pain sources. Yeah.
So part of what we do with the facet medial branch block is to tease that out. And so facet medial branch blocks, you have to be careful because you can get a lot of false positives, which are, I go in there, I use a high volume of numbing medicine around the facet joint, and I just kind of blast it. And then I say, oh, and the patient will come back and say, yeah, doc, that was really good. My pain went away for 6 or 7 hours. And then they go and they do the rhizotomy, and that's not really a good selected patient. You really want to use low volumes, a 0.5 ml or less. Usually it's a 0.5 ml. You really want to target where that nerve lives around the facet joint. And you really do it twice. One is for reproducibility. The other one has found to be, you know, usually an insurance requirement. They require twice, but it's more about reproducibility and ruling out false positives. And the other side of this is it's a temporary block. So that's another thing patients need to understand is it's not going to change anything. It's there to give us diagnostic information to say, do we feel the facet joint is involved? And is it worth going through and trying to ablate that nerve, which is a hot needle down around the nerve, which causes, it basically causes bone irritation, local tissue inflammation, and tries to stun that nerve and kill that nerve off for, a period of time. And then it's not permanent. So it can come back we hope 6 months to a year is a really good block, that's the reason to do this facet block, is to see is that the pain generator. So
I mean, facet pain, or this part of the lumbar spine that gives people arthritis related pain, I mean, it's a major driver of a lot of people's pain. And so some people are failing conservative management with physical therapy and medications, and then they try this block and then they go on to the rhizotomy, and some people are living on rhizotomies. They get it every 6 months, every year.
Yeah, I mean, you want to try and go as long,
silencing their pains.
Yeah, you want to try and go as long between injections as you can. So if you select and you get a really good patient with a small volume, really designated block, and they do really well, the key is to reproduce it, right? So you have to put the needle right back in the exact same spot, right where the nerve lives. And there's just so many variables that go into medial branch blocks and proper rhizotomies, and who to do and who not to do, and those kinds of things. And that's part of how we tease them out, and just kind of, and it's a process. So if you were to do a radiology report, which are written for physicians, not written for patients, most of the patients that I see, they come in and they start Googling every different term on there. Yeah. Facet hypertrophy, degenerative disc disease, stenosis, this, that, and the other. It's
very confusing.
And it's very confusing. And really, it's talking about very specific areas of the spine. And each one of those things can be a different pain generator. But really, honestly, patients usually have a collection of all of them. Mm-hmm. So that's what makes it hard to treat.
Yep.
So do you have anybody that walks in with a 3,000-page Google medical dictionary?
Oh my goodness. That's the standard.
Very close, yeah.
That is the standard.
Everyone uses Dr. Google these days. It's just to what degree?
Yeah, they scare themselves to death. And they, like I said, they take their radiology report and they start, reviewing all of these things. And they're like, Doc, what's this mean? Doc, what's that mean? And so I've actually thought about maybe doing a mini anatomy course, like some videos of some, common topics that they could review before appointments, because I do spend a lot of time debunking, stuff offline or not quite understanding offline. But I love that they ask questions, because that means that they're motivated patients and they want to learn and they want to know these things. And so I view that as a positive, but it's kind of guiding them to the right resources. I usually direct patients back to universities, University of Miami, University of Michigan, these university web pages. They have really good information. A lot of them have some good patient tools sometimes. And that's kind of where I go to, as opposed to like Bill Smith's back pain page or whatever. Sorry, Bill Smith.
WebMD.
But like you were saying, Dr. Williams, it's important that you know what your primary driver of pain is, because if you look on that MRI report, it's going to say that you have a herniated disc. It's going to say that you have something called stenosis. It's going to say that you have this other thing called facet arthropathy. But those are three completely different things in how they're going to present, how they're going to give you symptoms, and then how you would do something like interventional pain management, where you put the needle at. And so some people think that, oh, well, I've had an injection in my back and it didn't work, so I'm never going to do it again. Well, that was, like you said, initially, it's part of the diagnostic phase. Okay, it didn't work for you. Well, then you got to go on to the other things.
Right. And some of it too is, all these arthritic and degenerative conditions are by definition chronic and progressive, right? So one of the things that I talked a lot with patients is, well, Doc, I had an epidural 5 years ago. It worked fantastic.
Right. Just do it again, right?
And then you do the exact same injection. Like, well, that didn't work. The doctor must have not done it right. And I'm like, no. And if you look at comparative MRIs and you see this progression, there's a point where a steroid injection is really what this is. We call it an epidural because that's where we're putting the medicine, but it is a steroid injection in the case of radiculopathy. Now, if steroid injections worked for forever, would anybody have a knee or hip replacement? No.
Just keep giving me a shot every now and then.
Yeah. Right. And it's because they get to a point where there's a threshold where something for symptom control is not going to correct a mechanical defect, right? It's becoming past that point of, all right, now we're getting into severities that, a simple steroid is not going to help this, or a simple nerve block is not going to help this. Yeah. And setting expectations is really important with my patients, as I tell them, it's a different snapshot in time. We're targeting what your symptoms are today. We hope for 50% pain relief, because that's usually livable pain. So if you're at a 10 out of 10, which is maximum pain, and we can get you an injection, and you get down to 5 out of 10, people can usually live there.
Yeah,
right?
that's big. 50% improvement.
Yeah, if you get more, you're hopeful, but it's not just the pain, it's also the improved function. So like looking at somebody and saying, okay, yeah, my pain is down, but I'm not walking any better. And for some patients, that may be what they have to deal with because they can't, they're too medically complex to have a surgery, or, they just, they don't want to be on chronic pain medicine, which we don't recommend anyway. So, but there's certain populations that, that may be what their benefit is. But I look for functional improvement too. So you just don't keep doing these injections over and over and over again without functional improvement, or, some kind of reduction in pain that lasts too. So that's the other part of this is the injection has to last. So, a general rule of thumb is like 3 injections per year. There's no literature that says that, but that's usually, doctors don't like to do more than that. And it's 3 per year for your body, not 3 in my shoulder, 3 in my knee, 3 in my back, 3 in every joint. It's like 3. So, it can tend to be, from a steroid burden for radiculopathy, that's what you're kind of looking at. Is like, what's total body steroid? What are these things having? These things cause hormone problems and all kinds of other things. And so we want to just make sure they're working, I guess is the case. And part of that is teasing out which injection to do, which one's going to give them max benefits. And that's where the facet medial branch block comes into play, is to really see, can we prolong this duration of pain relief? And that's what the rhizotomy is for, is to prolong the pain relief.
What kind of patient is your most successful patient with the interventional, like let's call it an epidural steroid injection, just an umbrella term, with a cortisone injection in the back? Is it a person who comes in who has primarily leg pain and you see certain things on an MRI? What's going to be your best chance patient type who's going to succeed with a shot in their back?
So the best chance patient type in general is one who doesn't think that all I'm going to do is the injection and that's all I'm going to do.
Okay.
Right. That's number one, right? Doc, give me the injection so I can go back to playing golf.
It's got to be well-rounded approach.
Right.
Yeah.
But I don't want to do therapy. I don't want to do my home exercises. I don't want to do stretching. I don't want to do the weight loss. 350 pounds and I can't figure out why I have back pain. Like, these are the situations where it has to be well-rounded and it has to be persistent. Like they have to not give up. They have to stick to this. Their medication is their therapy, is their stretching, is their weight loss, is their whatever, right? That's the less risky of everything. Then there's somebody, depending on, we kind of look at it as, okay, does this patient have primarily back pain that doesn't radiate and doesn't really have any stenosis on their MRI, but has a lot of facet overgrowth? Those are the people you may target a facet joint injection first, right? And say, okay, and the injection being the medial branch block, not the inside the joint injection. Okay, so I'll make sure I'm going to call them medial branch blocks from now on, but they're addressing the facet joint. So you may do a diagnostic medial branch block, right? Because people have clinical symptoms that don't match their MRI pictures a lot of times, right? So you want to make sure that your diagnosis is definitely the back and there's no other contributing factors. People get stuck on back pain only coming from their back, but you can have back pain from higher up reasons too, like your neck, right? So you can have a stenotic neck that's causing downstream effects into the legs or arms or things of that nature. It may not just be isolated in the low back. So I kind of look and make sure on my physical exam and tie that in with imaging that they're not getting an upper level issue that could cause downstream effects like from up in the neck area too. And it really is teasing out on physical exam, really carefully listen to the patient history as to what their exacerbating factors are, what improves them, where they're really tender, what they've had done before that may have not worked, and kind of, so that's how you determine who the most successful patient is. Because I might be looking for somebody with more axial back pain or in the center back pain. But there's papers out there with facet that facet pain can refer pain. I guess, and what would be a good example of referred pain would be like
the chest pain. Someone's coming to the ER, and they're coming in with just arm pain, but they're actually having a heart attack, referred pain. Yep.
Perfect, exactly, because their heart is right underneath their sternum, but they're feeling it in their arm and in their jaw. Well, they don't have a heart in their arm or their jaw, So
yep, our brain just does a very poor job of localizing where the pain signals come from in certain regions like that.
That's referred pain. And so facets refer pain like that. They can refer it to their gluteal or behind their leg. And there's even reports of it getting below the knee down into the calf area, usually not below that, but yeah, you can refer pain. And that's part of the teasing out and trying to be patient with back pain. And it's hard because it's terrible and people suffer and they want a quick fix, but back pain is not a quick fix. It's not going to go away. And it's going to be a livable kind of pain is what we're trying to do. In some cases, we can make it go away, but then the question is for how long?
And what makes it especially difficult too is I see a lot of people whose nerves don't follow the textbook. You know, they're getting this referred vague pain from these tiny little facet joints in their back, but yet they may also, that a different person may have an inflamed nerve that's giving atypical radiation of actual nerve pain.
Right.
And we see it that way all the time in carpal tunnel. I mean, there's 3 or 4 different acceptable patterns for carpal tunnel pain, but we know where the carpal tunnel nerve goes to.
Right. And that's the thing is not everybody's the exact same. Like, you know, we use a bunch of different nerves, like, so we use like dermatomal distribution, we use cutaneous nerve distribution, we use myotome distribution, sclerotome. These are all words that we use in medicine to kind of give us an idea of like, okay, anatomically, everybody is about laid out the same. But it's not like this is where Florida begins and this is where Georgia begins, like, you know, on the nerves, right? Like there's some overlap. There's some, you know, kind of like, okay, the L5 nerve gives distribution here, the L4 here, but there's some overlap. And that's where kind of clinical history, imaging, you know, examining the patient, hands-on, this is really hard to do over a telemedicine visit. You can't say, oh, okay, bend over, twist, like, and like, you know, like you can try, but you really need to see these patients in person and, you know, kind of get a good idea. So,
you know, and I think it really takes it back to your first point. The more successful patients are the people who are actively involved in their health and what's going on.
Absolutely.
Because then they're the person who goes back home, thinks about some of the questions that the doctor asked. They're diarying what makes it worse, what doesn't. They're thinking about things through physical therapy. And then they come back and report these things, which kind of give us additional clues as to what's really going on and what's really the primary driver of your pain. And so, yeah, I think it really speaks to your initial point. That's why those people partially get better too.
Right. And I think the other part of like just back pain in general and facet pain, whether it's facet or radicular pain or whatever, is, so what do we know about chronic back pain, right? Like we know that chronic pain in general, if you get poor sleep, makes your pain worse. If you have untreated depression, it makes your pain worse. If you have a lot of psychosocial stuff going on at home, you know, from the environment there, it makes pain worse. So there's a lot of factors that, you know, anybody who has chronic long-standing back pain, they don't sleep good, they get cranky, you know, it
snowballs, it spirals on itself.
Spirals on them. So we need to kind of address back pain from a multifaceted approach where, you know, going to regular massage or going to physical therapy when it flares up. You know, people think PT, which is physical therapy. One time I did it in my life and I never have to go back. No, no, because there's a lot of stuff that they do in physical therapy that's not just the home exercises. They do therapeutic ultrasound, they do soft tissue massage, they do myofascial release, they do a lot of they can do cervical and lumbar traction. They can do a lot of things that can help when these flares come up. And if you have chronic back pain, you're gonna get flares. You're gonna have a baseline pain, and every couple times a year or randomly, you never know when, it's gonna flare up. And you're gonna have to go back to what helped before. And unfortunately, the things that we try sometimes, they fail. Yeah. Like honestly, like modern medicine has failed humanity in the fact that we have not figured out a good, solid, long-lasting cure for back pain, right? They're gonna get worse, hopefully not soon. Hopefully that doesn't happen to anybody, but that's the case. That's the reality of it. So a mental reset and really kind of understanding chronicity, living with chronic pain, understanding what I can control, what I can't control, that really helps people manage and live with like pain and stuff like that.
Yeah. Oh, and hey, Dr. Williams here in our last 5-10 minutes here. What are the other things that you're actively doing from an interventional pain standpoint? You know, we talked about the medial branch blocks and the epidural injections. Are there other things that that you're commonly doing with interventional pain to help people's back and pain and whatnot?
Yeah. So from like we talked about earlier, right? So sometimes people come with knee pain or back pain, and let's say it's knee pain, right? Or let's say it's hip pain. There's things that we can do for knee pain, you know, nerve ablations of the knee, whether it be with cryotherapy or with radio frequency ablation and things like that. So that kind of helps a lot of people who can't, you know, or don't want to survive, you know, living with knee pain, and they can't have a surgery. They're on blood thinners. They're just medically complex, but they're like, I want to play golf. I want to walk better. I want to do these things. There's things that we can do for them in the ablations, you know, realm. There's different types of injections. With regard to back pain, some upper, you know, people who've had back surgeries, what they call failed back surgery syndrome, are still having pain, or have had all these fusions and these things in the lower lumbar spine. We can, for a very select patient population, we can, that have literally failed everything else, we can try things like spinal stimulators and things like that to try and help with back pain and radiating pain. It doesn't help with numbness. It doesn't help improve motor function, like getting stronger. It's literally for pain and for back pain or radiating pain. And that's where like kind of stimulators kind of come in. Stimulators are little wires that live on the inside of the spinal canal, talk to the spinal cord, and block pain signals in an electrical way, so your body doesn't kind of perceive them. That's the easiest way I can kind of explain it.
A lot of people are familiar with like TENS unit. Would you describe it as like an internal type TENS unit, the way that it's stimulating the nerve, or no, it's kind of
no, definitely not. No,
oh, okay.
It's a different kind of pain blockage and a different kind of, you know, the way we use it. So without getting into detail, it's more of a,
yeah, it's pretty scientific and complex, those spinal cord stimulators, but
like electrical discussion, because we are electrical, right? Nerves use electricity, right? So it's like an electrical discussion between the wire that's inside your body with the back side of your spinal cord, which controls and regulates pain, right? Called the dorsal columns, right? So that kind of discussion can block pain signals. And we do a trial first. So we do a little stimulator lead, like just like you're getting an epidural done. And we run this little wire that lives on the inside, and we take it to the outside and put it in a temporary battery. And we say, hey, listen, you go home when you live with this for a week, and you tell me if it's really helpful for you. And we want really good pain relief here. We're not talking like 50% pain relief. We want a solid trial. We want 70, 80, the best we can get, the better, because trial implants sometimes lose efficacy once you implant them. They're not as good. So if you get a little bit of a drop, you know, 25%, whatever, then we want them to still work really well for you. And so some things need to be done before spinal stimulator trials are even considered. One of them is a psychologic/psychiatric evaluation. And one of those things touches on why, you know, I talked about in the beginning, is untreated depression, chronic insomnia, sleep apnea. These things, you know, they can cause pain. So that's one of it. We want to make sure you don't have anything else kind of underlying there, like an untreated depression or something. And two is you have reasonable expectations. Some people, this is a man-made machine that lives under your skin and in your body. And people, you've seen people with casts, right? They get all claustrophobic with a cast. They're like, get off my arm, get off my arm. Think about something living in your body that is man-made and may
do they kind of feel it, you know, different, or what do they describe that spinal cord stimulator like?
They just don't like it. They're like, get this thing out of me, and like,
oh, really?
So we wanted to make sure they have reasonable expectations that this is not a you know, it's to reduce pain. You're still gonna have pain, but is it livable, right? It's about setting expectations again. And so those are some of the more advanced upper level things for very select patients. And then if they do well in the trial, then you move to a surgical implant where they get a permanent battery and permanent leads. And that's a lot more to discuss here, but I would think that's probably the gist of it. So there's a lot of other cool things that people can do. So hope is not lost all the time.
Awesome. Yeah, that's good hearing that. And yeah, next time when we don't have as much, you know, technological issues like we had today, and as many snowbird patients, you know, demanding our attention, which is great. You know, we love taking care of patients. We'll have to really sit down and go through in a more complete way some of this spine stuff that we really just kind of brush the surface on.
Yeah, it's really complicated. So thank you for having me on and letting me just kind of talk generally right now, and you know, that kind of stuff.
Yeah, and you know, Dr. Joe, like you did with Paul Johnson, you know, it might be good on the television side to get, I guess, not a mannequin, but you know what I mean.
Oh yeah, get the spine models out. Yeah, the anatomic models for the knees, and yep. As we start to incorporate more of these videos, we'll incorporate that next time too.
Yeah.
And where did you
That might
post
be
the
a
last
good
video,
follow-up.
Greg? Was that to YouTube or what was
Yes,
the?
it's on our WPSL TV site on YouTube, and hopefully Michelle got it for your Florida Orthopedic site as well.
Yeah. And Dr. Williams, remind me, what was your training? I know patients always love to hear about people's training.
Oh yeah,
In our last minute here, real quick.
They always ask me where I went to school, and I went to all the schools. So, so I did 4 years active duty in the Marine Corps, and then after that I went to VCU for undergrad, and then after that I went to the Virginia College of Osteopathic Medicine, which is on Virginia Tech's campus there in Blacksburg, Virginia. And then I went to USF for my PM&R residency, and then after that, I worked for a little bit with you, and then I went back to pain medicine fellowship at Eastern Virginia Medical School in Norfolk.
Nice. All right. Thanks again, Dr. Jason Williams. And if you want to give us a call, 335-4770 for Florida Orthopedic Specialists, 335-4770.
All right. This has been great. Live from two locations, the main location of Florida Orthopedic Specialists on US 1, and Dr. Williams was down in Stuart at the location right there. This is WPSL, Port St. Lucie.